I will present to you our current work on the genetics of pituitary tumors. And today I will focus on Cushing's disease, which has taken quite a bit of our time and effort in the last 3 years in my lab. About 1/3 of the data I will present to you are unpublished, although they have been presented before in poster sessions and abstracts. I also want to acknowledge at this point my senior fellow, Laura Hernandez Ramirez, who was trained first in Mexico City, then by Marta Carbonitz, got a PhD in the UK, and now has been with me for 3 years. And this work has been largely hers, as well as most of the slides. My lab has received funding for research grants from Pfizer. This data that I'm going to show today is really a very collaborative effort from a lot of labs, both in the United States, mostly at the NIH, but also in France and elsewhere. So these are the various names. I do want to acknowledge Dr. Winman from the University of Colorado, and Dr. Dov Tiosano and Michal Cohen from Israel, Haifa. I'm going to show some of their data today. So you all know what Cushing syndrome is like. Pediatric patients with Cushing's have this very typical growth chart. You don't really need any of the laboratory testing. There's really no other disease that gives you unabated weight gain with stagnation of growth. Very typical growth chart. It's harder to diagnose in adolescents because growth is over. What I want you to always diagnose patients with Cushing's is at this stage, not when they get so sick. That's when the growth chart is completely flat. I want you to be able to diagnose this lady in the first 1 or 2 years of Cushing's disease when the growth is just slowing down, not stagnant, and the weight gain has just started. Cushing's disease is the most common cause of hypercortisolemia in adults and children over the age of 5. You know that I also work on the adrenal, but I'm not going to talk about the adrenal today. Clearly, adrenal diseases in children are more frequent below the age of 5. There have been a few molecular alterations in corticotropinomas, Cushing disease. They relate to loss of the glucocorticoid negative feedback, dysregulation of pathways controlling cell cycle progression, and overexpression of pathways sustaining overactive ACTH secretion. These data have not, however, revealed germline mutations that predispose to Cushing's disease, and I will show you today there are a few of those. So here is genetic causes of Cushing disease, the ones that I will be talking about, and some that I don't have the time to go over. In terms of familial, we think about 5% of all cases of Cushing disease in kids, of all cases including adults, and 20% in kids are genetic and familial. So most of those will be FIPA due to AIP mutations, MEN1, a couple of cases of Carney complex, mutations to succinate dehydrogenase subunit genes, neurofibromatosis, DICER1 mutations, and tuberous sclerosis. In terms of sporadic somatic mutations, the most frequent one is USP8. I'll show you some data on that. And then, of course, you all know GS-alpha, although there's only 1 or 2 cases of GS-alpha mutations in corticotropinomas. So here's what I'm going to be talking mostly about today. The AIP, MEN1, PRK1-alpha, DICER1, tuberous sclerosis, and the USP8 genes. Now, why would one be interested in trying to find genetic causes of these diseases? Well, because you do want to come up with specific therapeutic strategies. And for those of you who have taken care of patients with Cushing disease, especially pediatric ones, you know how frustrating it is when the first surgery fails. When the first transfemoral surgery fails, it's really, I feel for these kids. They don't have malignant disorder, but they have a disorder that really, really disrupts their quality of life. So in the case of acrogigantism, another disease that my lab identified molecularly, this has already led to therapeutic strategies that help with the disease. And so we hope we will accomplish the same with Cushing disease. There are new therapeutic targets that can be found. There is this one paper published by Shlomo Melmed showing that in zebrafish and murine pituitary corticotroph tumors, you can use a CDKI, a cyclin-dependent kinase inhibitor, for the treatment of Cushing disease. And again, from Shlomo's lab, Shlomo was the first to show EGFR signaling as the most important signaling in pituitary adenoma. So I don't think we're far from the day that at least some of the patients that failed pituitary surgery may be treated with EGFR inhibitors. Finally, it is very important for the patients and their families, because if they do have a predisposing gene defect, you can do targeted screening for other tumors. For example, if the child has an MEN1 mutation, or if the child has PPNAD, or if the child has an AIP mutation, then that means that he inherited or she inherited this defect from the family, and there could be other members affected. So you can do prospective diagnosis in other family members. And below I have some of these papers where we've applied all these principles. And genetic counseling, of course. So we expect an overrepresentation of inherited cases in a pediatric cohort. At the NIH, over the last 20 years or so, I've been studying a cohort that I collect every day. I mean, you all send me patients. I get patients from Europe. I get a lot of patients from Latin America and United States. But I have it, right now, our cohort is 268 patients in these 20 years, and you can see the demographics. I collect DNA from all the patients and their families, as well as the tumor DNA. And we screen first for the known genes. You may have seen some of the older reports that we've published on this. We showed, for example, AIP mutations, MEN1 mutations in patients with Cushing disease. We screened for GPR101. We didn't find any mutations except for one variant. And we screened for MEN1, and we found a substantial number of patients with MEN1 mutations. These are published data, so I'm not going to spend a lot of time on this. I'll spend a lot of time, some time on USP8 because I have some new data on that. So what we do now, once we screen for these genes, both the peripheral DNA and the tumor DNA, then we do exome sequencing for all the other patients. And then we confirm the findings by Sankar sequencing. We also do dosage analysis to identify carbon number variants that may be responsible for the formation of the tumor. And as I said at the beginning, this is a multi-center work. So far, in this group of 268, we've identified 5 MEN1 cases that were not known to be MEN1, 2 AIP mutations, and 1 with unknown genetic cause. You can see here 6 simplex cases from non-familial background, 1 AIP, 1 MEN1, 2 MEN4, so this is P27, and 1 tuberous sclerosis mutation. So overall, 4.9% of the patients had a potentially inheritable genetic cause. We identified USP8 mutations in this pediatric cohort in 31% of the patients. So here's the mutations we found in the USP8 gene on chromosome 15q. They are all in the published by Martin Reike hotspots, and the data were just published last year in this paper in GSNM by my postdoc, Faouz. The somatic USP8 hotspot mutations, this is a complicated slide, but it suffices to say all you need to get from this slide is that USP8 mutations in pituitary corticotropinomas lead to increased EGFR signaling, as Shlomo Melman had predicted from the Carney model of Cushing disease. The somatic USP8 mutations are by far the most common genetic defect in corticotropinomas. It appears to be a bit less frequent in pediatric cases. Now, I will show some unpublished data from our collaboration with Dr. Dov Tiosano. The data were presented, though, in a poster at the SPR earlier this year. So this is a case of a 14-year-old patient with Cushing disease who had obesity, short stature, thrombosis, and was found to have an ACTH-producing pituitary adenoma. Here is her tumor, which unfortunately occurred despite what appeared to be a successful surgery at the beginning. Here's the patient. You can see that in addition to the features of Cushing syndrome, she has a lot of other things, like, for example, disfigured nails, significant hypertrichosis. She has developmental delay and special faces, and peculiar hyperkeratotic skin lesions. Now, all of this will remind you of patients with increased EGFR. There are a few patients with increased EGFR signaling in the dermatology literature, and that will remind you of this patient. Well, what does she have? Dr. Dov Tiosano and his colleagues identified a mutation in the USP8, this time in the germline. So this is the first USP8 germline mutation that exists, and we are in the process of writing up the data. What does this mutation do? Well, fortunately, the mutation had been described previously in the Martin Reinke's group as a somatic change in 2 corticotropinomas, and like all other USP8 mutations in the hotspot region, increase EGFR signaling, and because it is present in the germline, this lady not only got an ACTH-producing tumor, but she also had all the other clinical findings consistent with increased EGFR signaling, for example, the hyperkeratotic skin lesions, the nail defects, and so on. Surprisingly, we also identified in our series of patients, in this cohort of 268, one patient that was seen first by us for an ACTH-producing tumor. And here I am. Dr. Spiliotis told you that I cloned the gene for Carney's complex 20 years earlier. And what did I do? I missed this patient with Carney's complex. And that is because this patient came to us with Cushing's disease, and he was an African American. So the only pigmented lesions were those in the eye. But to make the long story short, he had surgery for Cushing's disease. He had classic Cushing's disease. But then he recurred, and the recurrence was adrenal. When he recurred and the recurrence was adrenal-dependent, in other words, ACTH-independent, we also screened him for other lesions, and he had a large cell calcifying Sertoli cell tumor in his testes. So he had classic Carney's complex. And sure enough, he had a deletion in the PRK1 alpha gene. This was the first demonstration of a mutation in a gene that is known to cause mostly, almost invariably, adrenal Cushing's. And yet, in this one patient, it caused an ACTH-producing tumor in addition to an adrenal tumor. There is no question about the pathogenicity of the mutation, since this patient also had LOH in the tumor, so PRK1 alpha was shown to lose the normal allele at the pituitary tumor level. There are a few other genes that we have identified over the years in Carney's complex, mostly PDs and PRKC-beta. I don't have the time to go over them. I just want to remind you that we haven't screened at this point, and we haven't found any other genes causing Carney's to cause ACTH-producing tumors. But in this one patient, there is no question that also in the pituitary tissue, there was increased pKa signaling, just as we see in other tumors in patients with Carney's. Now, since our case was described, there's been one other case by Dr. Kiefer. This was published by Marta Carbonitz's group. And so they found also another PRK1 alpha mutation causing Cushing disease. And if you actually look carefully in the literature, there is one patient described by Krigler back in 1974, I believe it is. This patient was again reported as a case in the Mass General cases in New England Journal of Medicine in 2002. So this patient was never operated in the pituitary gland, so you can't be sure. But this patient clearly had Cushing disease by biochemical screening, and she also had, in fact, one of the classic PRK1 alpha mutations. So PRK1 alpha, a gene that was first identified in adrenal tumors causing Cushing syndrome, may also be responsible for very few cases of Cushing disease, pituitary tumors. Now I'll show you new data, new genes. So a year ago, we published this paper showing mutations in cables-1. I'll go over the data of this published paper because it's entirely new. What's cables-1? Cables-1, this is the cell cycle. These are cyclin-dependent kinases, and these are glucocorticoid responsive genes regulated by cortisol, and one of them is cables-1. What does cable-1 do? It regulates the expression of cyclin-dependent kinases, which in turn inhibit cyclin E. If you have inhibitory mutations in KBLS1, you will have less of the CDKNA, the cyclin-dependent kinase inhibitors. You will have more cyclin E, and the cell cycle will continue unabated. So we actually looked in our cases of patients with Cushing's disease, whether they had KBLS1's mutation, because there was a paper that was published in JCNM 2016 by Jacques Duren's group in Canada, showing that in some tumors producing ACTH, KBLS1 expression was downregulated. As I said, KBLS1 is a likely tumor suppressor and stabilizes cell cycle regulators as well as regulating apoptosis. So we sequenced 98 patients, and we also did RNA-seq from fresh frozen tumors from 35 adult patients. We studied 116 cases from NICHD, and the 35 cases were from Cushing in France, Hôpital Cushing, and this was a collaboration with Jérôme Bertherat. We identified 4 cases of variants in KBLS1 that are inhibitory variants. 2 variants in kids and 2 variants in adults. So 2 in our population of children and 2 in the adult population from France. Their location in the gene are shown here. And they are highly conserved in the sequence of this gene, indicating their potential pathogenicity when they are mutated. Very clearly, the in silico analysis of these mutations showed that they are, except for one, probably damaging. Interestingly, KBLS1 mutations, which are germline, and USP8 mutations, which are somatic, appear to be mutually exclusive. In other words, none of the 4 patients that had this germline KBLS1 mutation had a USP8 mutation in the tumor. And you can see that we stained here for ACTH, for KBLS1 and P27, and only one tumor had retained KBLS1 expression. All the other tumors had decreased KBLS1 expression, consistent with inhibitory mutations of a tumor suppressor gene. We tested these mutations in 80-20 cells, which are mouse corticotropinoma derived, and we were able to show with some variability that these mutations affected the growth of the cells. So the proposed model we have for KBLS1 mutations, and now we screen our patients for KBL1 mutations if they are USP8 negative. The proposed model is that inhibition of KBLS1 by missense variants that inhibit its function lead to an increase in the cell cycle in ACTH-producing cells. Now we have a new gene. This is totally unpublished, and I'll show you the data from this gene called KLLN. KLLN was sequenced again in 98 patients. Same principle. We did whole exome sequencing in 98, and then we sequenced by Sankar an additional 150 patients, so a total of about 250 patients. We also studied 138 cases for copy number variants from the NICHD cohort that included the KLLN gene. We identified 3 KLLN variants that appear to be inactivating the gene. The gene is on chromosome 10. It's a p53 regulated DNA replication inhibitor, and it appears to be co-regulated in its expression with a very well-known tumor suppressor gene, P10. So right here is the mutations were identified, the full sequence of the protein, and the DNA binding domain of KLLN. The patients that had these KLLN variants were 2 females, 1 male. They had slightly larger pituitary tumors than we usually see. On average, our pediatric pituitary tumors producing ACTH are at about 2.5 millimeters. And these tumors, you can see, were about 1.5, 2-fold larger. Now, these are still microadenomas. Those of you that have seen patients with Cushing disease know that most of the patients, pediatric patients in particular, that present with ACTH-producing tumors carry microadenomas. So these are slightly larger. Again, just like I told you before for the other new gene, KBLS1, the patients that had KLLN variants were wild type in their tumors for USP8 mutations. So we seem to be identifying germline variants that lead to Cushing disease that they are not needing USP8 in order for the tumor to progress. In all of the patients, or two of the patients, well, all the patients were operated, 2 were cured, and they remain cured at this point, but 1 is in remission, temporary remission, and he's right now on ketoconazole. Just like I told you before about Cables-1, Killen is also a pro-apoptotic cell cycle regulator. It seems to be regulating p53, and I told you before that's in the same location on chromosome 10q with p10, and the 2 genes that both regulate p53 seem to be co-regulated in their expression. And these are some references on what I just told you. There are other phenotypes that have been described with Killen dysfunction. Those have been mostly described by Karis Enck, a geneticist at Cleveland Clinic in the United States. So she described germline promoter hypermethylation in patients with Cowden's syndrome. Somatic defects of Killen have been described in breast cancer, renal cancer, and some other tumors that are affected by P10. So this brings me an interesting point. Whenever I see these patients, I always take a very detailed family history. And I find it not unusual that patients that have germline variants in a gene that is presumably pro-apoptotic and a tumor suppressor that have other tumors in their families. In fact, there is now increasing data that germline variants of genes in the population predisposed to a variety of tumors. And these are not necessarily disease-causing variants, but they are predisposing variants. And that's what I'm telling you about here. So you can see a gene that in the germline may be causing a predisposition to Cushing disease, but the same gene being mutated in breast cancer or renal cancer. Always in these kids with pituitary tumors, get a very detailed family history, because the likelihood is, if there is something genetic, whether it is a variant or a true mutation, that you will identify cases in their families. Now, it is hard to study Killen because it has 5 orthologs, but none of them in fish or in rodents. And my lab works both with mice and with fish, but we can't use fish or mice for Killen, unfortunately. So we have to rely on the studies on cell lines, and I'll show you some data on the HEC293 cells. These are human embryonic kidney cell line, and 8020, which is a rodent ACTH-producing cell line. And what you will see is that Killen affects the proliferation in these cells, and this is true for the variants that we described. Both the wild type and mutant Killen increases the expression of cyclin-dependent kinases, just like I told you before for Cables-1. And these are the specific cyclin-related genes in 8020 cells. Wild type, but not the mutant Killen, so the ones mutations we found, has a modest effect on suppressing the PMC expression in 8020 cells. Wild type and mutant Killen increases the expression of p53 and p73, while wild type, but not the mutant Killen, increases p10 expression as shown in these graphs. And the same is true pretty much for other genes that we checked in 8020 cells. Cell proliferation is also affected, although modestly. So you can see that 2 mutants had no effect on cell proliferation. The wild type had a suppression by 25% and 1 mutant by 16%. And there is an effect on apoptosis, as demonstrated by measurements of caspase-3 activity. In terms of looking at expression of Killen in the pituitary tumors we studied, you can see these are all ACTH-producing tumors. I'm not sure, this one has a little bit of ACTH staining, so you cannot see it very well. You can see that 2 of the tumors have lost Killen expression. 1 of the tumors has retained KLLN expression 1 with a mutation, but it is all nuclear. So as it often happens with tumor suppressor genes, some of the mutations, they don't abolish the expression, like here, but they just change the distribution of the gene from cytoplasmic to nuclear or from nuclear to cytoplasmic. So the model we think for KLLN and K+1 is very similar, except that KLLN is a little bit higher by regulating P53 and P73 in cohort with P10. But here's K+1, as I showed you before. The end result from the variants in these two new genes that I just showed you is an increased cell cycle in ACTH-producing cells. So I'll summarize the data. So far, in our 268 cases, we have identified 5 MEN1, 2 FIPA, 13 simplex cases with AIP, K+1, 1 Carney, 3 KLLN mutations, 1 MEN1, 2 P27, MEN4. A second, I told you at the beginning, we had 1 at the beginning, tuberous sclerosis. Now we have 2 tuberous sclerosis cases. And the collaboration with Dr. Tiosano's group, 1 germline USP8 mutation. Still, 91% of our patients have unknown defects that cause their tumors. And so we continue this work, which has been amazing. I have to tell you that this new data over the last 2-3 years keep amazing me. I don't think I would have predicted that so many cases would be genetic among our patients with Cushing disease. So I'll finish up here to accept your questions. Obviously, I'm grateful to my lab. I mentioned Dr. Laura Hernandez Ramirez, who did most of this work in my lab. But there's a lot of other people that have contributed, including Dr. Fabio Fauz, Dr. Nick Sedas, and Dr. Andrea Gutierrez Maria. I want to acknowledge the people in the clinic that get all your referrals, the patients that come to see us at the NIH for treatment. And here is when we celebrate our papers acceptances.